Chapter 21 talks about impulsive control disorder, and we are going to start with a clinical picture of a client that has been diagnosed with impulsive control disorder. Jeff is a 54-year-old. He's described by his parents as being rebellious to the point where he's really impossible for them to control him, no matter what approach that they take. He's been like this from since he was very small, and so the parents are saying they are at the wit's end with him. In fact, Jeff parents are not the only one concerned. The schools are concerned. It started back in kindergarten. Authorities have documentation about Jeff being very spiteful. He's very vindictive, and he's also physically aggressive. So this is basically like a clinical overview or clinical picture of a client with oppositional defined disorders, which we're going to talk about first. And as you look at Jeff's clinical manifestation, he he demonstrate those behaviors rather. He's very basically based on a positional defined disorder. These clients are angry. They're very irritable. They're defiant. They're vindictive. They have problem with social skills. They have problem interacting socially. They have conflict with the authority, and they have academic problems. So if you go back and look at Jeff, he fits this description of oppositional defiant. Also, based on the literature, ODD can also be contributed to ADHD. These clients will also have ADHD in conjunction with ODD. It typically starts at the age of 8, and you see it more often in males than you do females. And then, like I said, the comorbidity most common with these clients will be ADHD. Some of the risk factors could be genetic in nature. You tend to see a high incident of those clients that manifest at a younger age, but many of diagnosis based on their family history as well. And also, as far as neurobiological cases, there's been some documentation that these clients may have some deficit in their cognitive and emotional behavior due to some neurobiological issues. And these clients can be diagnosed using MRIs or fMRI, your functional MRIs as well. These are the two tests that could be used to diagnose. And with these individuals, you're going to see some abnormality in their brain structure, and they will have low brain activity as well. Physiological, these clients during the time of stress, most of these clients you're going to see an increase in their cortisol level. But with these clients during the time of stress, most clients, like I said, their cortisol level increases. But clients with ODD, it's been shown that their cortisol level decreases as a reactivity to stress. And then cognitively, these clients they have negative symptoms. Symptoms are acquired. Usually, like I said, these clients they want power. They they want attention, so they react to their parents when they can't get the attention that they want in a negative way. Environmental factors, again, it could be parenting, inadequate parenting, family distress, problem with attachment. So again, it can go back. It could be due to childhood trauma. So there are several things that could cause a client to act act out. This is a case study and a question that we're going to talk about in class as well. Another disorder we want to talk about is conduct disorder. And conduct disorder is basically, again, as far as these clients have persistent patterns of aggressive and destructive behavior. They also lack remorse for others. They like to break the rules. They feel like the rules and the laws do not apply to them. And usually we see this in kids or clients rather who've had academic failure, been suspended from school a lot. They're dropouts, become juvenile delinquents, drug and alcohol abuse, and then they usually end up in juvenile court for the most part. Also, there are some subtypes, basically childhood onset type, and which, like I said, individuals they must show at least one symptom before the age of 10, and then you have adolescent onset as well, and so these kinds they show no behavior before the age of 10. So it's usually later on after the age of 10, whereas childhood they're going to show those behaviors before the age of 10, and then adolescence after the age of 10. Also with conduct disorders, as far as the epidemiology is concerned, there's really no difference across race or ethnic lines. Um, you see it more common in those individuals that have been diagnosed with ODD as well. As far as comorbidity for conduct disorder, you see it again with clients with ADHD and also ODD, oppositional defiant disorders. So the comorbidities and the some of the epidemiology is pretty much the same with ODD. As far as risk factors, again, genetic could be genetic in nature, the environmental factors. Um, these clients also, again, they have a tendency to be very disruptive. They have as well. So and it could be genetically in nature. It also could be due to trauma that the parents um, usually may have had some trauma during pregnancy or something like that. So again, you see it with parents and also with or siblings with the disorder. So it's closely genetic. Neurobiological, again, it could be due to significant gray matter in the brain, and individuals usually they have problem with social skills. They're very emotional, um, and then they can also be unemotional as well. You can see some brain changes as well on your functional MRI. This is how these clients are pretty much diagnosed in conjunction with their clinical behavior. Environmental factors, I think I hit on that just a little bit. These, like I said, they have problems. They may have been disciplined very harsh by their parents. They may be abused. They may be neglected. They may be in an institution of living. You see a lot in foster children as well, um, due to large family household. The family members may have had there may be some alcohol or drug problems in the home. So again, it all goes back. It go back to the environment as well. Intermittent explosive disorder is another disorder. This is where a person has they can't control their aggressive behavior. Um, they very aggressive. They could be it could be verbal or physical aggressiveness toward other people. It could be toward animals and our property, even themselves. They can hurt themselves. They have which leads to problems with occupational relationship. They, because they're so aggressive, they can't control. They can't keep a job. Then again, they can't, remain in relationship. They it, always they entanglement with the legal system. And again, some physical symptoms that could lead to could be high blood pressure and diabetes could also lead to intermittent explosive disorders as well. It's particularly if it's under control. So significant problem with physical health, like I said, like hypertension and diabetes, have been linked to this order, to this disorder as well. So these people, these individuals, they may have a range of emotion. So they can be very explosive rather, if they get very angry. Again, you usually see this in clients also with depression. Those clients that have anxiety, substance abusers, anti-border social or borderline personality traits as well. like I said, ADHD and disruptive behavior disorders, also some comorbidities. As far as the biological um, instances, these clients, again, it could be they could have some physiological problems. Usually, they may have abnormally higher C-reactive protein levels also due to the decrease in neurotransmitters. Okay, and then environmental factors again. Going back to the environmental factors again, you can go back to the home environment, lack of parenting, and things of that nature. And your book talks about your military veterans being at risk for um, developing intermittent explosive disorder due to the PTSD connection there. Some other related problems are pyromania. This is where clients repeatedly, deliberately set fires. Um, so this is done solely to bring relief or pressure. They give them some relief. Like I said, they do it for no reason at all. They're relieving that stress or the anxiety or the aggression. Then kleptomania. These are habitual stealing. The individuals that steal habitually. Again, they are also related to impulsive um, behaviors as well. Not only these clients, not only do they steal, they also may buy a lot of stuff, just steal or buy stuff that they don't really need. So they have and it's usually when they become very depressed or they become have anxiety levels or eating disorder that like bulimia nervosa, personality disorder. They may also just buy stuff or they may steal stuff as you know, due to their disorder. As we assess these clients, there's some risk assessment tools, um, self-assessment tools, and suicidal evaluation tools. Um, Usually, you're doing the self-assessment tool, there's some guidelines that could be used, and there's a good. We're going to talk about a couple of those too. This self-assessment tool have been, help us to look at the client to look at objective behaviors and compare those. Again, these concerns should be addressed when we question the clients. Doing that self-assessment, have them to do that self-assessment. And if we do it with them, we also need to help them. We want to look at some positive attributes, some things, some positive coping skills. So these are some of your common negative attitudes that you may see with these clients. They sometimes they choose not to get better, and then they may feel like their safety is going to be in jeopardy, or whatever the case may be. So, as nurses, what we're doing when we're assessing our clients, we have to provide care to those clients that are equal care, equality care, be showing empathy, non-judgmental with these clients, and then also going back to the environment. What caused the problem? What's the origin of the problem? Going back to the environment, going back when they was a child, were they abused or neglected? Poor parenting, no parenting, where they, juveniles that stayed in trouble. So we have to look at all of that. And you want to know really caused the problem. As I've already said, if we can determine the cause of the problem, we can fix the problem. So there's the good assessment guidelines on page 397, assessment guidelines for ODD and conduct disorder and intermittent explosive disorder. So I'm just going to hit on a couple. So like I said, with ODD, we're looking at the guidelines here. We want to determine the issue that resulted in the power struggle, what triggers the outburst, when did they begin, and how they handled. So that's just one of the questions that could be asked when we the data part of the guidelines. I'm sorry. And then on the next page, there's a checklist. There's a little checklist here on page 398. When you're assessing a client, one of the first question: argue with adults. Never, occasionally, often, very often. So again, then we score those up, and then based on the scoring, then this is determine whether or not this client falls in that category. Again, it just basically help us to collect data and then asking the appropriate question. And as we know, the care is patient centered, uh, and also we have to collaborate with other team members as well. And also, as far as implementation, how we implement, we're going to look at some interventions or implementation. We want those interventions or implementations to include. We want to first of all, we want to make sure these clients are safe from and also we want to make sure that the other people that are around them are safe. We need to establish rapport with those clients, set limits and expectations. Also follow through. If they break the rule, what are the consequences? Again, we're going back to that milieu environment that we talked about. It has to be a structured environment, and again, and also we have to set boundaries. Activities. We want to promote activities and give these clients an opportunity to achieve their goals. Okay, so again, when we're caring for these clients, we make sure we not controversial, non-judgmental, and also as far as trauma informed care, we want to make sure, again, going back, promoting an environment for these clients that is safe, uninterrupted when we providing care, unintentional. We don't want to re-traumatize these clients. So we want to make sure we wouldn't go in and ask like, what happened to you? You know, what happened to you versus what is wrong with you, or set the stages. So we want to be very, very compassionate when we're asking those questions. So going back to therapeutic communication, going to be very critical with these clients because the way we ask that question, again, they may become very defensive, and again, we could trigger an episode. Like I said, team safety. We want to make sure you have uh, the amount of team members, particularly when you're caring for a client, because if they become agitated, aggressive, you need to have enough, manpower. Again, now we don't want to seclude anybody or restrain anybody without de-escalating them if it's all possible. Therefore, we need to collaborate with all team members, let everybody know what is going on with this client. What are some things we need to look for? Okay. So we want to communicate to these clients in a calm manner, compassionate manner. And then when we giving direction, we don't want to say, for instance, you sit down. You want to say, Mr. Jones, can you calm down? Can you please have a seat? So don't be direct, or I am in control. You don't want to be authoritative either, because this can also escalate the situation. As far as biological treatment are concerned, like I said, going back to you, following up with your seclusion and restraints, we talked about that. Going back to chapter 6, if you need to review those, how to manage your client, in restraints or seclusion, you may want to refer back to that chapter. The FDA, USDA, and FDA, U.S. Food and Drug, or FDA, I'm sorry, has approved of some drugs that these clients could benefit from. Um, Depakote, it's a mood stabilizer. Piprazole, it's another drug that has been approved by FDA that these clients will benefit from. Also, SSRIs, risperidone, also has been approved for these clients. So they're your selective SSRIs. One example would be fluoxetine or Prozac, or Lexapro may be another example. So go back to your list of drugs and kind of look at your SSRIs, and then again your mood stabilizers. They could be beneficial. Um, Piprazole, of course, is one of your second generation um, drugs, antipsychotic drugs. Then beta blockers have always that's also may be helpful in calming those clients down as well by slowing down the heart rate and reducing the blood pressure. However, we do not want to use benzodiazepine with these clients because they can further reduce in uh, reduce inhibition and also self-control in the same way as alcohol does. So we give them benzodiazepine, that medication will have the same effect as alcohol. So we want to avoid those medications. As far as therapies are concerned, psychological therapies, your CBT therapy, you see the trauma-focused negative cognitive behavior therapy. Then we see the family management training, parent-child interaction, social skills training. These are several therapies that we can incorporate in this client plan of care as well. And again, we will talk about this case study and this question tomorrow in class. This ends the presentation for chapter 21.